Well, I want to take a minute and just talk about something that perplexed me for a little while when I was in school, and that is how to read a culture and sensitivity table. So before we do that, though, I want to take you back to your maybe freshman year of high school. That's when this happened to me. I remember being in biology class, and we took the toothpick and scraped the inside of our cheek and put it onto a slide and stained it and did all that stuff, probably made a mess of our clothes, and then looked at it under the microscope. Well, what we saw then was cells from inside of our mouth, and those cells are epithelial cells, right? No surprise there, but keep that in mind because you're going to need that information in a minute. The other thing that you're going to need is remembering that PMNs, or polymorphonucleocytes, also known as macrophages, are inside the lungs, right? And inside of a lot of tissue in our body. In fact, they're inside the liver, they're inside the spleen. And it's these cells that help fight infection from within those places that interact with the outside. So when we do a bronchoscopy, we get a specimen from there, and we're never surprised to find white blood cells. And when we classify gram-positive or gram-negative organisms, we know something about them. Well, what we know about them is their relative complexity, right? So gram-positive organisms are relatively simple. When you look at the gram-negatives, you see a whole lot more stuff going on here. And that whole lot of more stuff going on makes it very difficult to treat these infections sometimes. When we know that they're gram-positive cocci, that helps us to understand what the organism may be and pick the right antibiotic to treat it. But the other thing that we have to know is how good is the specimen that we got? Yes, we grew some gram-positive cocci, but there's lots of gram-positive cocci, and sometimes they're organisms that belong there in the mouth, for instance, and sometimes they don't belong there, like in the lungs. So how can we use the knowledge from high school biology class to figure out whether this is a good specimen or not? Well, what we do is we stain everything that's in that specimen, and when we stain the white blood cells, we'll see them under the microscope. And if we have epithelial cells, we'll see them as well. So remember that the PMNs, or the macrophages that we find, live in the lungs. So if we get a specimen that has lots of PMNs and hardly any epithelial cells from the mouth, then that's really reassuring that we have a good specimen, right? So we can believe that the gram-positive cocci that are identified in that sputum culture are important pathogens. Make sense? On the other hand, if we get mostly spit in that sputum specimen, then there's going to be lots of epithelial cells and few, if any, PMNs. And so we got saliva instead of mucus from the lungs. And that's important to know, that the gram-positive or gram-negative cocci that we found in the sputum are not important when we think about this, right? So let's look a little bit more in depth at these reports of sensitivity and specificity, the reports of sensitivity. In this case, we're looking at a report that is a finalized report. It says final results here. And we found that the source of this information is from a wound. The site is the right hip. And we have preliminary results at 1 day. We have preliminary results at 2 days. We have preliminary results at 3 days. And then finally, in the final results, they've identified 2 organisms. They've identified Proteus, which they call organism 1, and list all the sensitivities here. And then they've found MRSA, which they've listed as organism 2. Now let's look down here. Remember that MRSA stands for methicillin-resistant Staph aureus. Now, I want you to look at this and tell me where you see that they've any information that they could identify this as methicillin resistant. Methicillin's not even listed here. Well, this is one of those little tricks that the ID guys never tell you because they always want you to consult them. No, I'm just kidding. They don't make methicillin anymore. They only make oxacillin. So when we identify an organism as methicillin resistant, we're actually identifying it based on its response to oxacillin. All right. And if we look over here, we can see the R and this number. We can ignore the number because that doesn't really tell us the relative benefit of any of these antibiotics when compared with one another. We only know how that response is comparing as a self-control. So we're going to ignore the number in most cases, and we're just going to look at whether the organism is resistant to that, as it is to ceftriaxone, or whether it's sensitive. And when we see that it's sensitive to gentamicin, that might be something that we would want to use. The problem is that we don't have gentamicin in PO form, right? So maybe there's another medication that is PO form. And in fact, there is one here. This is a sensitive, this organism is sensitive to TMP SMZ. By the way, while we're on this topic of classifying organisms, another classification that we can use is whether the organism is anaerobic or aerobic. Well, it always puzzled me that you could have an anaerobic organism growing in the mouth or in the lung, right? That didn't make intuitive sense to me. So I want to make sure that you're crystal clear about how that can be. Remember that anaerobic bacteria don't require oxygen, and sometimes they die in the presence of oxygen. Now, the other thing that's true about anaerobic infections is that they are often the patient's own flora. And how can that be? Well, the reason that patients grow organisms of their own flora, that become an infection is that infection gets walled off from the blood supply, and therefore oxygen can't get to it, right? Think about where abscesses grow. Let's say you have a tooth abscess. If you have a tooth abscess, that abscess is growing organisms inside where there's no blood supply getting to it. So what's the other important thing to know about that? When there's an abscess, it has to be drained, right? You're never going to get enough antibiotic to that spot to treat that infection without draining the abscess, because by its very nature, you can't, because the organism is walled off. The infection is walled off from the blood supply.